All right, so we'll get started. Topic today is what you need to know about metastatic bone disease and the treatment options. I don't have any disclosures that are relevant to this topic. Metastatic carcinoma, it's a big word, and it essentially is a cancer that has spread. And since I'm an orthopedic surgeon, what I'm dealing with for the most part is cancer that's spread to the bone in people that have advanced disease. This could be a lung cancer, for example, that has become advanced and actually spread to the bone. It's probably the most common thing we see in bones over the age of 40 when we see something that looks aggressive. And it's a significant quality of life issue for cancer patients because you can imagine this can be quite painful and sometimes cause fractures. So it's quite important for us to keep their quality of life in check, and sometimes we do surgery in order to help with that. The most common tumors that will spread to bone are breast, prostate, lung, thyroid, and kidney cancer. This is a little bit of a complicated scheme here, but what it's showing is the cancer essentially invades the bloodstream, and when that happens, it can get to the bone. As bones have a vascularity to them, they have a blood supply, and essentially they can sometimes stay dormant in the bloodstream, which is, unfortunate. That's why sometimes it can come back 5 years after people's initial cancer. Sometimes it comes back right away, but sometimes it can lay dormant and then pop up in the skeleton. Depending on the cancer type, I have patients that live for years, even when dealing with metastatic bone disease. If this is something that presents very early on in the treatment, then survival rates are worse. But the treatment goal is essentially to relieve pain, preserve function, and quality of life. The pain comes from the cancer being in the bone. It weakens it, and it's worse in weight-bearing bones. You can imagine, since you have to have your entire body weight walking on your hips every day, it's a much bigger deal if it spreads to a hip than, say, a wrist. Sometimes we have to be a lot more aggressive surgically so we can keep people out of a wheelchair and keep people functional. And these bone mets can be very painful at times, and surgery is one way of helping relieve that pain. The hips, the arms, it is kind of rare to have it happen closer to the wrist. It usually is in the upper arm and the thigh. And essentially what we would do is get an x-ray. So if you're a cancer patient and you know that you have metastatic disease, say you're on stage 4 disease, you're on systemic therapy, or maybe you've had radiation in the past, it's just important, if you do have severe pain, to let somebody know, because sometimes as easy as just getting an x-ray will let us know if there's a more serious problem, or maybe it is just a sprain or strain that has nothing to do with your cancer. But it's always safe to get an x-ray and just let somebody know that you are having pain with ambulation or are having more pain in the arms with function. Sometimes people don't know they have cancer, and we find this out because they have pain and go to the doctor, and an x-ray shows something worrisome. Then we start looking in the entire body, essentially. This is a picture of a kidney. It's kind of a cross section of a body, almost like you slice it like a loaf of bread, and you can see the kidneys, the one on the left, a lot larger than the one on the right. And getting this scan showed us, okay, this person has this painful bone lesion. That might be where it's coming from, is from a kidney cancer. And it essentially can look very different in bones. All right, you can have a punched out hole that you can imagine looks painful, right? That picture on your left-hand side has that area of bone that's actually missing, and you can imagine that may be at a very high risk of breaking. On the other side, you can just see that the bone doesn't look quite normal. You see the normal bone at the top of the screen there, and then at the bottom you see all these ruffles and deformed shapes of that bone. Even though it doesn't have a punched out hole, it's still thick and white appearing. It's not normal bone, and it can make it also more prone to fracture and pain. Sometimes we might need to get a biopsy if we really don't know what the diagnosis is. We never want to assume anything. We have to prove what it is that we're working with. And that can be done by a radiologist or sometimes in the operating room. So if we know we're dealing with what we call a pathologic fracture or an impending fracture, meaning one that I'm worried is going to break, my patients and I come up with a plan. I don't have a crystal ball. I don't know exactly which bone might break and which one won't break, but I have an idea from experience in our training which ones may be higher risk for that. We can talk frankly about life expectancy. You know, is it something the patient can live with and it's not that painful, or is it truly leaving them bedbound? And that's not quality of life if someone's fighting cancer, even if it's short for 6 months to a year, or it might be 5 years. We just have no way of knowing. And quality of life is something we're trying to restore. Some options that are not surgery, if we're not quite as worried about it breaking or it's not quite as painful, radiation is a great option. Radiation is something that we use a lot even if we do surgery, because we're trying to kill the cancer also right in that spot so it doesn't keep growing. Bisphosphonates are essentially drugs that help build calcium. So you can imagine if the bone's weak because of the cancer, and we also use it for like osteoporosis, this helps us to regenerate some of that bone, such as in that picture where that hole was. Sometimes these drugs can kind of help develop new bone. Radiation can help with palliation of pain and local tumor control. And we won't go too much into the medications, but the medical oncologists are who typically prescribe those. So when we don't do surgery on pathologic fractures, meaning a fracture that has the cancer in it, sometimes treating them in a cast or in a brace can take a much longer time to heal. So some fractures, even if we would treat them in a cast in a patient that didn't have cancer in their bones, we might be more aggressive in someone with underlying cancer because we really want to get them back functioning. A bone scan can also show, you can see that black fleck that's kind of on the arm of that skeleton. That is an area of that actual same picture that we showed you back here. It lights up on the bone scan because there's all this bone activity from the cancer. Bone scan is a good test that can help us see how many of these spots does someone have. Is it really only one? Do we need to be worried about more than one bone? And here's that picture again, and you can see in this patient, it did break, right? For whatever reason, the decision, if the patient didn't want surgery or, you know, this is a tough problem. Some are a lot simpler than others to fix. This is a pretty diffuse lesion in this bone, but eventually you plate it and fix it so that the patient has a stable arm. Sometimes we treat these bones before they break. That is actually ideal because and I'll show some more pictures here. This is a patient that, is there a marker on this? I'm sorry, I just don't want to turn it off if it is. Is it the green? Or I didn't know if I could. Oh, on the pointer.
And then you can just use the mouse.
Okay, perfect, thank you. So you can see this dark spot at the bottom of the bone. That's essentially an area in the bone that the cancer has made a hole and has disrupted the strong cortex. And you can see what I ended up doing is putting a plate and filling that hole with cement that gets hard right away. So I know this looks like a giant plate, but it probably takes like an hour of surgery, hour and a half. And then instead of having horrible pain, patients can get up and walk on it right away. And we avoid it breaking in the first place, which is wonderful because then we're not having to worry about fracture healing. So then we typically will radiate as well to try to kill any cancer that's remaining behind. We're going to go through a lot of different things we can do. It's not just plates and screws. We can put rods. We can actually replace joints. And sometimes we just use cement to fill defects if they're not very large or we don't think they need a lot of fixation. We're a lot more aggressive with legs and knees and hips because you are walking on them every day and we want to keep people mobile. So in an arm, some people may say, I don't want surgery. I'll take it easy and I won't pick up anything heavy. I won't do a push-up. I won't do anything, crazy. And sometimes those we can give them time to heal or radiate them and avoid surgery. Also depends on how much pain the patient's in. So again, it's a very individual decision. Here is an arm that you can see this shadow. Oh.
Wait, on the screen, like if you move the mouse onto the actual screen.
Oh. Sorry.
What's that?
Not seeing it over there.
Why it's not- it's like hardwired.
That's okay. You can see that shadow in the arm. It looks very subtle, but it's almost like I hate to say it for lack of a better word, almost like a cheese grater right in that area. And that weakens the bone. And so we're able to fix it with a rod. You can kind of see how that bubble, where the cancer kind of progressed. But once we have this rod down, he was able to heal and reform the bone. And it's a huge satisfier for patients that were having extreme pain every time they try to lift their arm or try to brush their teeth or brush their hair. It really does restore quality of life. You can see that bright white dot in the bottom of that knee is one we just kind of scraped out and put some cement so that it wouldn't get any bigger and wouldn't cause pain. And that helps with pain control. On this one, you can see a dark shadow at the bottom of that knee joint. And there's a large piece of bone kind of missing there from the cancer. And this looks also like a very large surgery, but we replace it with metal. And so all that painful bone that was about to break, all of that cancer, we cut it all out and actually replace it with a fancy knee replacement. And this also allows for weight bearing immediately. Sometimes tumors can bleed a lot, and we have tricks up our sleeve where we can actually have the interventional radiologists essentially go through a vein and cut the blood flow off to these very vascular tumors. That helps with them shrinking and helps with pain control as well. Here's another example of a rod to stabilize a bone, where you can see there's an area of missing bone there on the left, and that rod is just bypassing it to help. Eventually, the cancer didn't stop growing in that region, so we cut it all out. And yes, this also looks like an extreme surgery, but if people can't walk, this gets you up immediately weight bearing, and patients actually do very well with this. We can talk about a lot of different examples of going back in and plates and screws, and again, all with the purpose of trying to restore quality of life. This patient, you can see multiple spots and patches throughout his pelvis, and one of those hips is actually broken. So we go in and fix it like we would a broken hip, even in somebody that didn't have cancer, and again, allow for immediate weight bearing. This one's probably a little more obvious on the left, and because of that, we go in and replace it, and the patient's able to walk again. So kind of more examples of the same thing. This is a break above a knee replacement because there was cancer in the bone. And we go in and we put a bigger knee replacement so that patient isn't lying in bed for 3 months trying to get that to heal. So in summary, many patients have great quality of life despite of bone carcinoma. People can live for years having metastatic bone disease. It's typically not something we can cure, but with all of the new immunotherapies, new chemotherapies that are coming out daily, we can sustain patients' disease and actually try to keep it at a minimum. And so if it does pop up in a bone and they're having quality of life issues or having extreme pain or fracture risk, we can help them go out and live a meaningful life with surgery as an option. So time is precious, and I look at this picture of my kids, I can't believe how old they are. So it flies by, and we want to make sure that even in spite of our patients with end-stage disease, that they too have time with their families and quality of life. Typically it's pain if it has gotten to the bones, and that's very generic, right? Because if it's an elderly patient too, we have patients that have knee arthritis that might be knee pain. An x-ray is a very simple test to check for that. So in anyone that's high risk, say you know you've had cancer, or you're in remission and you develop any sort of deep achy pain with ambulation or with new activities, it's never a bad thing. It's a simple test to get an x-ray. A lot of folks that already know they have metastatic disease are being followed by oncologists, so they're getting PET scans, they're getting scans every so often to make sure their treatment is working or if it has to be tweaked. So they a lot of times are seeing this, right? And they're the ones that call me and say, hey, I really want to get my patient in to see you because I want your opinion. Do you think they need surgery? Do they not? So pain is typically the biggest thing that we see. You saw the one test I had up there was that bone scan. That will show us if there's any activity in a bone. Just because something lights up on a bone scan, though, I don't want people to worry too much. A bone scan picks up anything that is making bone. So a fracture can light up on a bone scan. Arthritis can light up on a bone scan. But it is a test that if we're truly worried about spots in the bones, this will show us. And so in our diagnosis, a lot of times if patients get a diagnosis of cancer that's not metastatic, their doctors are ordering, PET scans, bone scans, CT scans to make sure there's no spots anywhere else in the body. And that's usually pretty a sensitive test. There is some blood work you can also do for some cancers. Multiple myeloma, prostate cancer, you can check for PSAs. There's some different blood work that the oncologist can sometimes do as well. But those are pretty much the go-tos to see if there's anything in the skeleton. Yes, especially if there wasn't a mechanism that made sense for why the bone was breaking. But the other reason for some of that may not be cancer is just metabolic bone disease like osteoporosis. People can definitely have weak bones and break the same bone over and over again or break multiple bones, and it has nothing to do with cancer. But obviously, again, that is a red flag if that is happening to anyone. I can see a patient like that. We have Dr. Crone, who is our bone health specialist, that all he does is deal with metabolic bone disease and trying to prevent fractures in people with osteoporosis. So he would be someone that might treat someone with recurring fractures that is not anything to do with cancer. If it's not some extreme case where there's just really no bone, and even if that was the case, we would probably replace the hip. Replacing it, you can bear weight right away, but the recovery is probably a little bit longer because it's a bigger wound, etc. A rod, especially to prevent a fracture, I typically tell my patients that I keep them overnight in the hospital just because I want to make sure their pain is controlled. But honestly, you could even go home the same day. Most people spend one night. Some of my frailer folks or older folks might be there a couple of days, but we allow weight bearing immediately. So the nice thing about the rod is if we were worried about it breaking before and everybody said, don't walk on it, don't, stay in your wheelchair, it could snap, don't do anything. Then we stop worrying about that. And we say, yes, it might be sore, get up and walk on it because we've supported it now. And we can get people moving and prevent other things like blood clots, pneumonias, all the things that happen when you're not able to move around effectively. So it's a pretty quick recovery. The surgery is probably about an hour long, very small incisions because we're using x-ray to kind of guide us to put this rod in the bone. And it's pretty effective. No, chemotherapy gets into the bloodstream, so that will get everywhere. Bones have a great blood supply, and it gets to the bones just like it gets anywhere else. So chemo absolutely helps treat these bone lesions, whether we do surgery or not. For example, say multiple myeloma, which is technically not a carcinoma, but it is a disease that affects multiple bones. Very chemosensitive, and sometimes you can have large holes in a bone, and we leave them alone, and once they start treatment, they start to fill in with bone. So chemotherapy definitely gets into the bones. I wouldn't think of the bone as being a barrier to the chemo. So when we talk about bone cancer in this setting, it's always another cancer. When we're saying it's metastatic cancer to the bone, it's always another cancer that's spread. So it's going to be kidney cancer, prostate, could be anything, could be colon. It's more rare, but That's essentially what we're talking about when we say bone cancer. So you're really targeting that cancer with whatever chemo is going to treat the mother cancer, if we want to call it that, whether it's the prostate, the kidney. There are other types of malignancies that can start in a bone that are not metastatic cancer. There is a type of bone cancer called a sarcoma that originates in a bone, and we treat very differently. It's not really the scope of this talk, but like that's something children can get, that we do chemotherapy and surgery in order to eradicate that cancer that's in the bone, but that was never a cancer that spread from somewhere else. The stuff we're talking about here with metastatic bone disease is a cancer that started somewhere else and spread, so the treatment for that cancer, wherever it is in the body, would be the same.